Hello, everyone. Our topic today is about breast cancer pain. I would like to start with this quote here for George Orwell. In the face of pain, there are no heroes. Our objectives today is to go through prevalence of breast cancer pain, definition of total pain, neoplasm-related pain, treatment-related cancer pain, post-mastectomy pain syndrome, breast cancer pain management, and we'll end with some key learning points. Prevalence of breast cancer pain. Breast cancer does not usually hurt. Research shows just 6% of people diagnosed with breast cancer report breast pain as a symptom. However, a rare type of cancer known as inflammatory breast cancer can cause breast pain. Breast pain is more likely due to hormone fluctuations from puberty, menstruation, pregnancy, or menopause. Studies have consistently shown the incidence of post-mastectomy pain syndrome to be 50% between 24 and 36 months postoperatively. Total pain. Dr. Cicely Saunders coined the term total pain and suggested that the pain can be understood as having physical, psychological, social, emotional, and spiritual components. The combination of these elements is believed to result in a total pain experience that is individualized and specific to each patient's particular situation. Again, total pain is physical and non-physical, spiritual, emotional, and social. Physical, we have three elements: nociceptive element, inflammatory element, neuropathic, and then you have the non-physical components here that we just mentioned. The nociceptive is non-neuronal tissue damage. Inflammatory pain is defined as increased sensitivity due to the inflammatory response associated with tissue damage. Neuropathic is pain arising as a direct consequence of a lesion or a disease affecting the somatosensory system, either central or peripheral. Another terminology is here: acute, chronic pain, and transitional pain. Acute pain resolves with healing of the causative agent and has a protective biological function. Chronic pain is a pain lasting beyond expected recovery period, and identifiable pathology is insufficient to explain the pain state. The relatively new terminology is transitional pain, and there's a lot of interest on this new, evolving terminology here. Transitional pain care is focused on treating patients who are at risk of transitioning from acute to chronic pain following surgery to prevent the development of chronic pain and related disability. Types of neoplasm-related pain. According to Dr. Foley, we have 6 types. We have acute neoplasm-related pain, chronic neoplasm-related pain, treatment-related pain, patients with a history of pre-existing pain, patient with a history of drug abuse, and dying patients. I always, explain to my fellows that, neoplasm-related pain are basically 6 different animals, and you cannot treat, these 6 animals the same. Each one has its specifications, and thus, you cannot apply the same rules to every type of pain that you're dealing with. Treatment-related pain is the one that we be focused on in this presentation. As you see, we have post-chemotherapy pain syndrome, like, chronic peripheral neuropathy, especially with the Texans drug, avascular necrosis of the femoral or humeral head, gynecomastia with hormonal therapy, for example, for prostate cancer, a chronic post-surgical pain, postmastectomy, and others. We're going to be talking about, during this presentation here in detail. Chronic post-radiation therapy pain syndrome, especially in the case of breast cancer pain, is brachial plexopathy. So our focus today will be about post-mastectomy pain syndromes, because we can wrap it up in one presentation here today. Okay, so first, an introduction to mastectomy. We have 6 types of mastectomy here. Okay, we have simple or total mastectomy. We have extended simple mastectomy. We have modified radical mastectomy, Holstead radical mastectomy, extended radical mastectomy, and super radical mastectomy. I mean, you don't have to go, deep in all of these, but I want to say that the more complex the surgery is, the higher this incidence of pain in these patients, post-operative pain. I mean, naturally, because of more tissue damage, more axillary dissection, more nerve injury, and so forth. Post-mastectomy pain syndromes, according to Jung in Pain 2003. The commonest type is neuralgia, intercostal brachial nerve, neuroma formation, and phantom pain. And then we have other nerve injury pain. These are the commonest types of nerve injuries for breast surgeries. Post-mastectomy pain syndrome. It's a neuropathic pain syndrome. Pain and altered sensation in breast, axilla, and chest wall. Intercostal neuralgia. Dissection of the axilla and scar pain. This one is intercostal brachial neuralgia. This is a kind of a screening test for neuropathic pain, composed of 4 questions here. Post-mastectomy pain syndrome, neuropathic pain descriptors, electrical, burning, shooting, stabbing, positive signs and symptoms, such as allodynia. Allodynia is pain on simple touch, dysthesias, phantom sensations, negative signs and symptoms, numbness, and anesthesia dolorosa. Anesthesia dolorosa is basically deafferentation pain syndrome. Here, intercostal brachial nerve, as we said, that's the commonest nerve that gets affected here. It's the nerve that supplies the floor of the axilla. Phantom breast pain is basically pain after mastectomy. Patients still having sensations and numbness, tingling in this area, pain, and it comprises around 5 to 10% of of all of post-mastectomy pain syndromes. This is a central phenomenon, okay, and thus you have to work on it by using anticonvulsant drugs such as gabapentinoids, for example. Phantom breast pain. You have to differentiate this from phantom sensations. Phantom sensation is just that the patient has the feeling that of the breast that's lost, but it's not hurting the patient. Phantom pain is the patient is feeling the breast that's lost and it's hurting them. Chronic pain following breast surgery. We have breast cancer surgery, 50%, mastectomy, 50, phantom breast pain, 5 to 10%. Features of chronic pain after breast surgery. Daily pain, 50%, moderate to mild to moderate, 90%, severe, 10%. Chronic pain syndromes. Secondary pain syndromes, such as the ones in the arm and the shoulder. We have frozen shoulder, neck and shoulder myofascial pain, trigger points, lymphedema, complex regional pain syndrome, cancer pain syndromes like local invasion, metastasis, and treatment effects or neuropathies. Risk factors for chronic pain. High body mass index, younger age, preoperative pain, such as patient having fibromyalgia, for example. Please take out this breast fibromyalgia, just fibromyalgia. Severe acute postoperative pain, more than 6. Complex surgery, like revision and reconstruction. Nerve injury, axillary dissection versus sentinel nodes. Radiotherapy or chemotherapy, limb immobilization, frozen shoulder and CREPS, complex regional pain syndrome, lymphedema. Risk factors with breast pain: tumor recurrence, infection, neuropathic pain, trauma, the mnemonic stent. Psychosocial risk factors or CHAMPS, catastrophizing thinking, home, in other words, family support, anxiety and depression, medically focused, passive coping style, social support. Prevention of chronic pain. Avoid unnecessary surgery, especially cosmetic surgery. The surgical technique. Of course, this is not something that we can tell the surgeon what to do and what not to do, but if it's possible, adopting nerve-sparing surgeries will reduce the risk for getting post-mastectomy pain syndrome. Screen and monitor at-risk patients. Preventive analgesia techniques. Multidisciplinary rehabilitation. Breast cancer pain checklist. CAMP therapies, behavioral therapies, physical therapies, pharmacologic, such as NSAIDs, lidocaine patch, opioids, and adjuvants. Pain interventions like nerve blocks and pulse radiofrequency and trigger point injections, surgical interventions, chemotherapy, and radiotherapy. I want to revisit with you the WHO analgesic letter. I mean, all of you guys are aware about it, okay? It's step one to step three. Now they kind of modified things a little bit. They added step four, where they added the nerve blocks or the interventional pain block. Also, they kind of clarified these steps. If you're going up, this is basically for chronic non-malignant or cancer pain. While if you're going down, this is probably in the situations where you have um, acute pain or chronic pain that's not well controlled. One of the important devices we use in acute pain is a PCA machine. And this is going to be a separate presentation by itself. Of course, right now we have disposable PCA machines. We use it a lot at Ain Shams University. Um, Regional anesthetic techniques. I wanted to explain to you the philosophy of regional anesthetic techniques nowadays. Okay, we used to do in old days the central, we call them the central regional anesthetic techniques, such as thoracic epidural, paravertebral blocks. Nowadays we shifted to peripheral. All right, and there is a reason beyond that. The central are the gold standard. Nobody can argue about this. This is the ones that will give you the best quality of pain relief. But they have their own, adverse effects and complications that you can avoid by doing the peripheral blocks. With the peripheral blocks, they are much simpler to apply and they are much safer. Like, for example, erectospiny plane block or serratus anterior plane block. These are the ones like involved in breast surgery. Okay, so there are much more than this, of course. But I wanted to give you the concept here. Um, the the ones central blocks, you cannot do them in anticoagulated patients or patients that had spine injury, while you can do peripheral blocks in those patients. Thoracic epidural, of course, we do it, different ways. You can do it a landmark technique. You can do it ultrasound guided or under X-ray. Paravertebral block uh, is a very important block that we used to do in old days. We still do them, the thoracic and the paravertebral, but because of the you know uh, presence of new peripheral blocks, we tend to go to do the peripheral blocks that are much safer than these ones. Like erectospiny plane block, I'm not going to go through the techniques because this is a separate presentation by itself. Just try to remember the names. Serratus anterior plane block. There's a newly published article that compared the serratus anterior with the erectospiny and the paravertebral block. And basically, they found the superiority of the serratus anterior plane block, and it's almost as effective as the paravertebral block, while the erectospiny wasn't useful in postoperative analgesia in breast surgery. It could be helpful in other surgeries, guys. Okay, don't misunderstand that erectospiny plane block is a very important block. But I'm just saying in this situation here and that we're talking about, the serratus anterior plane block seems like very logic to me. You know, it's very safe. As you can see here, you're totally away from any structures that you can injure, and you can do it ultrasound guided. And look at the amount of analgesia you get from serratus anterior plane block. It's just enormous. So this is something I would choose if I want to go and have breast surgery here. I would love to have the serratus anterior plane block. Okay, it provides me with the adequate analgesia that I'm looking for without having the major complications, that can happen with thoracic epidural, for example, or paravertebral blocks. Okay, we're gonna go through some of the things that we do as well here. This is the intercostal brachial nerve that basically get always affected in um, breast cancer surgeries. A suprascapular nerve block. We do a lot of these, especially in cases of frozen shoulder. Okay, these are some interesting injuries that happen here, like long thoracic nerve pulse. This can lead to weakness of the serratus anterior muscle and can lead to pericapsular pain and winging of the scapula. Look at this. Difficulty elevating the arm above the shoulder level. And one of the main causes is iatrogenic trauma, like mastectomy. Frozen shoulder is another complication that can happen post-mastectomy, and it goes into 3 stages. Okay, stage 1, 2, and 3. Stage 1, there's severe inflammation of the shoulder joint, and then stage 2, the pain starts to subside, but you still have stiffness in the shoulder joint. At stage 3, the pain and stiffness of the shoulder and overall symptoms gradually subsides. I can tell you, I had experience with these cases. These patients, I mean, they come to you in the clinic, they're miserable, okay? And, after treatment, injections, physical therapy, they start to get better. So, but I always tell the patient, after a year, probably things will get better. Of course, this is not a great answer for the patient, but uh, the good news is if we do injections and acupuncture and physical therapy, probably this will accelerate the healing process in your situation. So I just wanted to explain that this is a self-limited phenomenon. Okay, but you can help the patient by accelerating the healing process by doing injections, trigger points, acupuncture, physical therapy, and usually and even medications. You know, because at the beginning it could be very painful. Okay, chemotherapy-induced peripheral neuropathy. This is a very painful condition. It happens especially in patients on Texans, and it presents with numbness, tingling in the hands and feet. Patients can lose reflexes. They can get ataxic. So this is really a major complication here. And usually we give the usual, anti-convulsants and, Cymbalta and all that stuff. But I just want to say that, unless you stop this medication, it's not going to get any better. Radiation-induced plexopathy. This is also a serious problem. It could be very painful. Okay. The treatment is the same, like it's a neuropathic pain. Osteoporosis. Osteoporosis can happen for several reasons here, like premature ovarian failure, impaired gonadal function, and drugs that block estrogen here, such as the tamoxifen aromatase inhibitors. Another complication from postmastectomy pain syndromes is lymphedema. Okay, and the treatment of lymphedema, guys, is manual lymphatic drainage, garment, compressing garment to be applied, physical therapy. It's not treated with diuretics, okay? I'm very clear about this. No role for diuretics in treating lymphedema. A rare but pretty serious complication of lymphedema is developing lymphangiosarcoma, or we call it Stewart-Treves syndrome. And it's usually ipsilateral, developed in patients, that had lymphedema 3-5 years after the development of the lymphedema. And presentation is usually multiple subcutaneous nodules. Of course, you need a biopsy to verify the diagnosis. And, the usual treatment is surgical by amputation, and it carries really a poor prognosis. Another common issue um, that we see is, uncommon, neuropathic pain syndrome is called the CRIPS, or complex regional pain syndrome. Uh, it's not a common problem, but you need to know it, because if you treat it early on, okay, you can actually get very good results. It needs an early intervention. So there is a criteria for CRIPS called the Budapest criteria. I'm going to show it to you. You can use it, okay? But I have my own simple criteria, all right? I want to share it with you. I call them the 3Ds. Number one, D is disproportionate pain, okay, affecting the upper or lower extremity. Usually, of course, in the case of breast surgery, it will be the upper extremity. Number two is dystrophic changes. You know, what do I mean by dystrophic changes? Color changes. The arm turn red or turn blue, with increased or reduced sweating, autonomic changes in the extremity. Okay, so number two is dystrophic changes, and then number three is diagnosis of exclusion. You excluded everything, and then you have this pain amount of tremendous amount of pain. This is called, basically complex regional pain syndrome, or in old days, reflexive lymphatic dystrophy. There is a variant of complex regional pain syndrome. It's called CRPS type 2. So we have 1 and 2. 2 is usually related to, major somatic mixed nerve injury. Okay, this is called, CRIPS type 2. It looks exactly the same like the CRIPS 1, but it has the nerve distribution of the affected or injured nerve. This is the Budapest criteria, or you can, look it up from the internet, and you can use it to diagnose, um, complex regional pain syndrome. All right. Another important issue is myofascial trigger points. Okay, myofascial pain. Now, I want to say this picture is beautiful. This is out of an article I'm going to show you in just a second. But they showed the exact location of the or the commonest trigger points that it can happen after breast mastectomy, and it's around this T4 T5 area in the inframammary area here. Okay, so I wanted to kind of share it with you because this is really important. And you can block these with some local, very superficial. Okay, you don't need to go in the intercostal nerve, and you just block them with some local and steroids. Trigger points are underutilized, procedure. Despite that 33% of the cancer pain patients that arrive to the pain clinic are basically are myofascial trigger points. And I want to say that uh, I've done a lot of these, and patients, for their surprise, they get improved, and they go home very satisfied from a simple straightforward block or injection. Anyone that have the basic knowledge of trigger point injections can do it. It doesn't need a big physician, and that's why I always, teach my fellows from palliative, from medicine, from neurology, whatever. Whoever wants to learn it, I teach it because I know how to do it and how to get the best out of it. Okay, you can basically treat 1/3 of the patients that's coming to you in the clinic by knowing this simple, procedure here. So, what does the trigger point do? It breaks the muscle spasm. Okay, and this breaks the, energy, the ischemia the patient having and the pain. When you have a muscle spasm, you're reducing the blood flow to this area, okay, of the body, and of course, this will lead to energy crisis and pain. So when I do the injection, I'm just breaking this muscle spasm cycle. You can use lidocaine. I use only diluted, very diluted local anesthetics like lidocaine, 0.5%. Okay, you can put a touch of dexamethasone if you want to, but I rarely do so. And you can even do it with dextrose, 5%. Okay, you can do it with even acupuncture needles. Trigger point injection for post-mastectomy pain is simple intervention with high, rate of long-term relief. This article I quote from Dr. Amal El-Khouri, 2021. They just look her up and you'll find this article, and it can explain to you the trigger point injections after the surgery. Of course, after breast surgery, you can develop trigger points in other parts, like in the neck, in the upper back. There are, multiple areas. All this shoulder area, neck area can be affected. Okay, but this is one of the commonest sites. Is the one located in the inframammary area there. Key learning points. Studies have consistently shown the incidence of post-mastectomy pain syndrome to be 50% between 24 and 36 months post-operative. Pre and post-operative pain, complexity of the surgery, and whether the patient received radiation or chemo seriously increase the risk of pain. The pain is extremely variable, uh, being mild to moderate in 90% and severe in 10% of the cases. Pain can be treated using interdisciplinary technique, including behavioral, physical therapy, pharmacological, and interventional injection. Thank you.